Welcome back to the Pro PA podcast. I'm your host, Prof G, and you're tuning into another clinical medicine brief in the MSK101 series, where we break down high-yield musculoskeletal topics straight from the PANCE blueprint. In this episode, we'll cover fibromyalgia, a frequently misunderstood but incredibly important condition you'll see in both outpatient and inpatient settings. Let's dive in. Did you know that fibromyalgia affects around 2 to 4% of the general population? And women are affected 7 times more often than men? It's one of the most common causes of chronic widespread pain, but often gets dismissed or misdiagnosed, even by experienced providers. So let's look at the kinder patho. What is fibromyalgia? Well, fibromyalgia is not an inflammatory or autoimmune disease. It's best described as a central sensitization. Basically, the CNS, or central nervous system, processes pain signals abnormally, leading to an amplified pain response to stimuli that shouldn't normally hurt. Think of it like this: the pain volume is turned up too high, even when there's no real tissue damage. So, how do these patients typically present? Well, chronic widespread musculoskeletal pain, often described as hurting all over. They also tend to have fatigue, non restorative sleep, and cognitive disturbances, called fibrofog. Symptoms must be present for greater than or equal to 3 months, and it frequently coexists with anxiety, depression, or IBS. Tender points, used historically, are no longer required for diagnosis, but still a popular board exam focus. All right, so how do we make the diagnosis? Well, it's a clinical diagnosis, so there are no definitive lab tests, but we must rule out other conditions like hypothyroidism, rheumatoid arthritis, lupus, and polymyalgia rheumatica. So, some labs to consider for workup are a TSH, an ESR and CRP, an ANA or rheumatoid factor if autoimmune is suspected, and a CBC and CMP to rule out anemia or other metabolic causes. Remember, normal labs in a patient with chronic pain and fatigue, think fibromyalgia. As far as treatment is a multimodal and patient-specific plan. Now, there are some non-pharmacological treatments, and this is considered first line. We want to encourage aerobic exercise. This has actually been found to be the most effective method of treatment for fibromyalgia. We can also suggest some cognitive behavioral therapy, and we can give patient education on sleep hygiene. As far as pharmacologic options, we have a few that we can try. We usually start with TCAs like amitriptyline, and this is what's commonly tested on board exams. We can also prescribe SNRIs like duloxetine or anticonvulsants like pregabalin or gabapentin. But we really want to avoid opioids. They are not effective and they may worsen the pain perception. All right, book med versus street med. So, book med. Fibromyalgia is diagnosed using the American College of Rheumatology criteria, and treatment is tailored through a structured plan involving meds, therapy, and exercise. The street med, well, patients often show up frustrated, feeling dismissed, or told it's all in their head, and there is real skill here. And the real skill here is validating their experience while guiding them towards consistent self management strategies. All right, some quick clinical pearls to wrap this up. Consider fibromyalgia in middle aged women with normal labs, chronic fatigue, and widespread pain. Exercise is the most effective therapy. Encourage low impact options like swimming or walking. Avoid unnecessary tests and long term opioid use. And remember, fibrofog is a real thing and it can mimic early cognitive decline. All right, so now that we've gone through this, let's do a couple questions to test our knowledge. Question 1. A 38-year-old woman presents with chronic fatigue and diffuse musculoskeletal pain for the past 6 months. Labs including ESR, CRP, TSH, and ANA are all normal. Which of the following is the most appropriate first-line therapy? Is it A, NSAIDs, B, cognitive behavioral therapy and exercise, C, prednisone, or D, tramadol? I'll give you a few seconds. If you said B, cognitive behavioral therapy and exercise, you are correct. Remember, non-pharmacologic therapy is the cornerstone of fibromyalgia management. Question 2. Which of the following findings is most consistent with fibromyalgia? Is it A, elevated ESR and joint swelling? B, morning stiffness greater than 1 hour and positive rheumatoid factor? C, widespread pain with fatigue and normal labs? Or D, proximal muscle weakness and elevated CK? I'll give you a few seconds. If you said C, widespread pain with fatigue and normal labs, you are correct. This is the classic presentation of fibromyalgia. All right, so some final thoughts. Fibromyalgia can be frustrating for both the patient and the provider, but your approach makes all the difference. Recognizing this condition early, educating your patients, and supporting them with the right tools can drastically improve outcomes and quality of life. Thanks for joining me on this clinical medicine brief of the Pro-PA podcast MSK101 series. Be sure to follow and subscribe so you never miss an episode. And as always, this is the Pro-PA podcast, where future pros in medicine are made. See you soon.